Thank you very much for being here, gentlemen. We're here to talk a little bit about what happened at the consensus workshop on MRI. I'll let you each go through and give your own perspective to start, and then we'll ask a few follow-up questions. Dr. Hewett, would you like to start?
Sure, yeah. I think there were two goals from my perspective from the consensus. One was to establish what was called the core MRI, and one was to establish the investigational MRI for Ccsvi. The goal of the core MRI protocol was to develop a protocol that could be used anywhere in North America or the world, I guess you could say. A MRI protocol that could be used to evaluate patients with Ccsvi before they were to get a procedure or in follow-up. This MRI protocol is intended to fit a time space that would be something that would fit in with the schedule of your typical imaging center or busy hospital imaging schedule. Relatively uncomplicated sequences in addition to normal brain MRI that would be something that a typical radiologist could learn pretty quickly and make comments on quite rapidly. Not a really big sea change from doing a normal MRI of the brain. As it stands now, there's many patients all over the world who request to have an MRI evaluation of their brain, of their neck, of their veins to help determine if they may have Ccsvi or an abnormality of their venous flow. And the lack of availability, I think, of an MR evaluation in that regard is a strong impediment to moving the science forward and moving the acceptance of neurovascular underpinnings for neurodegenerative diseases forward. So that's the core MRI. A lot of progress was made in that regard. As a second tier, we touched upon speaking of the investigational MRI at certain select sites where people were perhaps willing to travel and have a more extensive MRI that looks into many more different aspects of what we're looking at here in the conference with regards to patients with MS and their brains and other neurodegenerative diseases in their brains. And hopefully by issuing a consensus statement, both in the core regard and in the investigational regard, we can move the basic science of investigation of venous flow and CSF flow and other abnormalities of the brain in patients with neurodegenerative diseases forward in a more meaningful fashion.
Thank you. Dr. Haacke, do you want to add to that?
Well, that was very elegantly put, Joseph, so it didn't leave too much for me to say here. I would add to that, I guess, that I think one of the things that we're really missing for the patients is the ability to use that data both for their own benefit, pre and post-treatment, and especially for follow-up as well, because having an MR scan at the beginning is an important control for them. And they may get treated now, but they'll be scanned a year from now and maybe several more years from now and for probably a very long time. So having that data is critical, and having the right information in that data for them is critical. So as Joseph said, we'll have a new core Ccsvi addition, which will basically include a 3D image of the veins of the head and neck and upper part of the aortic arch, and it will include flow quantification. And these two may prove to be some of the most important information to follow for the patient. So if the patient had a stenosis and that was seen initially and then he was treated and did well, and then maybe a year later wasn't doing well and came back and found out that he had re-stenosed, you would be able to monitor this. You would also be able to monitor the flow and see, did the flow improve pre and post-treatment? Or does the flow generally remain stable over time? And so having this fairly simple core that I believe only adds about 5 minutes to the current protocol that's being done in most hospitals really opens the door for doing that. For me, as a scientist, to complement Dr. Hewett's interests, is that we have access to that data then. And that data may prove, once we've collected thousands of cases, that we can really demonstrate that the flow in MS patients is abnormal compared to that in normal controls. The second tier that he referred to would be adding something like perfusion-weighted imaging to measure oxygen delivery to the brain and look for any local deficits, and susceptibility-weighted imaging to be able to look at the small veins in the brain, and also to be able to quantify the iron content, because we don't know yet if people actually get better, if the amount of iron will be reduced or not. And the iron may actually serve as a biomarker for the status or progression of the disease. So for those people who participate in that level of research, then you will be able to learn a little more. And maybe there's even a third tier, and that is there's always new sequences being developed, sequences that look at molecular diffusion in tissue, very complicated sequences involving what we call spectroscopic imaging that measure metabolic function, and they can even tell us if the neurons are working properly or not. But all of these take much more time to run. So I think our goal now is to put together a white paper on this, as Joseph said, that we can publish this, and that way clinicians, research scientists will all have access to this data.
Okay. Dr. Feng?
I don't have too much to add on. I only want to say one thing is because I'm been analyzing the hundreds of cases of data. So one thing that we do notice is the lack of normal control data, which is is kind of something very important, because we have to base the comparison of the patient data to the normal data in order to really distinguish what's abnormal and what's normal. So hopefully, I know this conference is an academic conference, but hopefully we can get more people, the MS Society involved, and we can get more data and from the normal controls, so that we can do a full strength, more rapid progress on the research front.
Okay.
That's all I want to add.
The rest of the questions, I'm going to throw the question out, and whomever feels comfortable answering it, please feel free to do so. Would you say that measuring flow utilizing MRI is reliable from machine to machine and institution to institution? Are there any concerns about that?
From my personal experience, there is definitely a difference, from machine to machine, from operator to operator, from site to site. However, the important thing, I guess, since we're doing the research, doing the analysis, we are always keeping this in our minds, and so we have, for example, when we analyze the flow data, which is cardiac gated, which means that the machine will record the patient's heart rate, which can always, first of all, it varies, and then the accuracy could, they could fluctuate. So that's one thing that will induce some kind of errors in the flow measurement. But however, when we do the analysis, we actually normalize our venous flow with respect to the arterial flow, which is collected together. So whatever error is introduced on the venous side is also proportionally introduced in the arterial side. So we try to do, through this kind of normalization, we try to control whatever the error that's could be introduced.
I'm told that there's some proprietary software, Dr. Haacke, at your company that you're utilizing. Is that software that would be licensed elsewhere so that other institutions can have a more consistent means of being able to read and monitor data?
Well, that's an interesting question from the processing point of view. As Feng just said here, he's got a technique to evaluate or handle some of the errors that are there by normalization. But there are many types of software, and the question is, are the softwares also consistent from one to the other? These are certainly things that should be evaluated. And the companies have their own software, individuals have their own software. We have something called spin software. Actually, up to now, our software has been available and free on the internet. And there are many sites around the world that are using this software. We're constantly developing it, however, and even now we're developing the flow capabilities for this. We're looking at evaluating simulated data, phantom data, human data. We're looking particularly even for consistency of taking the same person and scanning them many times and making sure that the results are fairly consistent. There's not something strange happening physiologically. Again, as Feng said, cardiac gating is extremely important here. So if it works, then we want to make sure there are no problems in actually processing that data.
And I understand that your consensus workshop was on, creating consensus around MRI, but in each of your opinions, how does this compare to ultrasound results in terms of accuracy?
Well, ultrasound does a beautiful job of collecting real-time data. So every few milliseconds, almost continuously, really, you're getting ultrasound data. So you can monitor every heartbeat with ultrasound, and you can evaluate what's happening in a given vessel. And you can move along the jugular, you can change to the carotid artery, but it's kind of limited in the sense that it can access things easily near the surface, but it's harder for it to get down to the aortic arch, for example. It's much more difficult to do intracranial work. The advantage that MR has is MR basically sees through your body, so to speak, and we can get images there that are not impeded by bones or anything like this. So we can collect all the vessels simultaneously when we do. The disadvantage for us is it takes us 128 heartbeats roughly to get our data. So we're assuming that the heart beats consistently each time we do that. And assuming that's true, then I get a cross-sectional piece of information that has all the vessels in it, all the arteries, all the veins. So then you can go and draw each of those vessels and calculate the flow through each vessel. And so it's very efficient, and it can be done anywhere in the head and neck or body. And so it does have its limitations because you're gating it, but it's pretty consistent. So each of them has their trade-offs associated with them. But I think if we use this trick that Wei was talking about by normalizing the venous to arterial data, we're finding that our results agree pretty well with what you see from Doppler ultrasound. So I think this is a good thing because then you have the potential to compare between modalities.
What would you say is the most significant disadvantage of each of the modalities?
I think the true strength of ultrasound is its accessibility and availability, and also the dynamic nature of the investigation. So if you turn that on its head, MRI exams do tend to be more expensive, somewhat less accessible, not so much in the United States as in other parts of the world. And of course, it's very difficult to, when a patient has their MRI, they're essentially lying in one position. You don't necessarily get that ability to move them into different positions. The downsides with ultrasound are some of the things that Dr. Haacke mentioned. These global pictures of the anatomy, the ability to look at flow in the chest and in the head, the ability to do many more things such as quantify iron, look at CSF flow. The toolbox, so to speak, with MRI is quite a lot bigger than it is with ultrasound. It's just that the ultrasound toolbox you can put in your pocket, the MRI, you gotta have a truck.
Why is it important for the patient to have the opportunity to move positions when you're measuring flow?
When you're looking at flow and the fluid dynamics in our veins, they change when we're standing and when we're lying down. And this can affect many of the things that we're talking about at this meeting, and so it's important to be able to measure them in some ways in both positions. And this is why, in my mind and in my opinion, it's not so much of a either or. Ideally, these exams are complementary, and a patient would have access to both.
So as part of your meeting, did you look at or think about the minimum and maximum scan times for patients going through an MRI in order to properly diagnose CCSVI? Was that part of what you were hoping to set a standard for?
Well, it's a consideration. It's not so much that we want to say, I think, no MRI exam should be longer than X in a sense. There's a community standard, I would say, for a typical MRI of a brain in an MS patient. Someone goes for their yearly MRI, for instance, and this MRI lasts a certain amount of time, and the infrastructure for imaging centers and hospitals is oriented around these relative times. So when we looked at setting up this protocol for a core MRI, we wanted to be relatively close to that number. If we were going to double that number, you can imagine how there would be a pretty strong resistance, both logistically and financially, to doing something like that. The investigational MRI is a little bit different because by the sheer nature of what it's there for, time constraints don't provide so much of an impediment on the study.
What are the most critical takeaways from your consensus that you really feel must be conveyed?
I think the most important thing for the patients is to get their baseline scans. They have to know what they looked like before they're treated. Only then can they know if they benefited from it in an objective fashion that can be quantified by the doctor. It's a little difficult, if a patient is going through ups and downs and may feel well one day and not well the other day. But the MR or ultrasound scans, they're going to show you quantitative information. They're going to show you if you have new lesions. They're going to show you if you have increased iron content. They're going to show you if you have a stenosis. And finally, they're going to show if you have reduced blood flow. So all of this information is really critical. I think the really exciting thing is that based on some of the work that Wei has done, and I'll just mention it, and Wei, maybe you might want to comment a little bit more on it. We've analyzed about 300 data sets from 2 different sites, and we're seeing a trend that a certain fraction of the MS population shows very low blood flow in the internal jugular veins. And when we look at the normal population, we don't see that. So there may be a cutoff below which you may be at risk. So if it turns out that flow actually is a potential risk factor, then this could be very important for people who have MS or have children who they're worried about having MS, or just generally in the future, and maybe not using MR, maybe using ultrasound. If you could use ultrasound and screen the total flow the way we're doing, you may be able to say that person's at risk for MS, you should watch out what's happening. So I think this could be coming down the road as a great benefit for all the work people have been doing in this area.
Dr. Feng?
Regarding this, the analysis that we have done 300 cases, about 300 to 400 cases from each side actually. We basically did a simple categorization of these patients. We divided them into 2 groups, one group with a normal appearing jugular vein, the venous system, the other one without a normal appearing one. So what it turned out is that the second group that has a abnormal appearing jugular vein system, they have significantly reduced flow, which is normalized by arterial flow. And we have about 25 to 30% of all those the abnormal appearing cases that has the jugular flow less than 50% of the total arterial flow. That means over a majority of the venous flow is not exiting the brain through the jugular veins, but through other collateral veins, smaller veins. Now that doesn't mean that the venous blood does not exit the brain. It only simply, in fact, we have found that there's no difference between the total arterial flow or even the total venous flow between any groups, even compared to the limited number of normals. It just means that the more venous blood is exiting the brain through collaterals, which could have increased the resistance and which could lead to further physiological responses.
You raised a point there about the normals, and it's a comment that's come up in every interview that we've done, is that there seems to be a significant concern that there's not enough work being done with patients that are considered to have normal blood flow. How do you solve that? How do you increase the amount of patients that are willing to be part of a baseline approach and a way for you to continue to further and standardize this work?
Well, it's not so much the patients we need, it's the spouses of the patients. It's
Okay.
People who are not directly related that might have a genetic link, for example. And I think the best way to do that, we are calling that the Millennium Project at the moment, meaning we want to collect 1,000 normals. And we want to try to do this with several sites, and Joseph can probably speak to that in a minute because he's one of those sites, and he's trying to do something like that. And if we can involve, even 3 or 4 sites that are collecting a few hundred cases each, we'll get 1,000 cases pretty soon, and by this time at this conference next year, we will have irrefutable data as to what's normal and what's not normal. And this is one of the most important points that's really being ignored so far. And that's why having that standard protocol is so important, because as that data begins to be collected from site to site, if it's done the same way, we'll be able to use it in this analysis and therefore increase our statistical certainty about what we're doing. Joseph?
Okay.
I think one of the major questions and one of the major stumbling blocks in making the ideas that neurovascular disease is important in neurodegenerative diseases accepted by other parts of the medical community is the presence of a venous abnormality different in someone with a neurodegenerative disease than it is in someone without a neurodegenerative disease. And we need these normals to be able to tell us. How are we going to know what hot water is unless we felt cold, right? At our site, we have a study called the Verify MS study, and along the lines of what you're asking, how do we do this? Well, we say to our patients, when you come down as a patient, what we'd like to do is take your non-blood related partner, spouse, friend, and offer them for free an MRI. And that way we accumulate normals, trying to rope the normals in while we get the MS patients. And hopefully by doing this and other such mechanisms, we can accumulate enough of these normals where we can present really robust data to the world saying, we can now say for sure, because our numbers are large enough, that this is the incidence of a Ccsvi venous abnormality in an MS patient versus a control subject.
That's fascinating. Would each of you like to say anything to wrap up? Any point that I may have missed that you feel is important to address?
I would just like to say, in terms of your second to last question, one of the biggest takeaways for this, having developed this core MRI protocol, it's going to make the study hopefully more ubiquitous and accessible, not only to MS patients, because the ISNVD isn't about multiple sclerosis, it's about neurovascular disease and neurodegenerative disease, and there are many types of that disease. So hopefully this core MRI protocol, which is very simple to implement anywhere, on any magnet, anywhere in the world, can be used to evaluate patients not only with multiple sclerosis, but also with Alzheimer's and Parkinson's and migraines and a variety of other neurologic abnormalities in a very simple fashion, using a language that everyone can speak.
Thank you. Dr. Haacke, did you have anything to add?
No, I exactly echo what Joseph has said.
Dr. Feng?
No.
Thank you so much, gentlemen. Greatly appreciate you
you.
taking the time.
Thanks.
And now you can